Dr. Jeffrey Lieberman, a great pleasure to have you with us on Mental Wealth today.
Thank you. Thank you for accommodating my schedule.
So, schizophrenia is arguably one of the most complex, misunderstood mental health disorders, which is why we are so pleased to have you with us on the show today to help us understand this mental health disorder better and to demystify some of the information out there. So let's start off first, if you can, Dr. Lieberman, by defining schizophrenia and explaining to us how common this mental health disorder is.
Schizophrenia is a brain disorder that affects parts of the brain that are involved in people's thinking, their perception, and their emotional regulation. And it has its onset normally within the adolescent years, beginning after puberty and then extending into young adulthood. So you could say 15 to 25 years of age for the most part. It manifests itself in the form of disturbances in these mental functions that first begin gradually, but then worsen and take the form of what are called psychotic symptoms, meaning disturbances in thinking which cause people to have false beliefs. They're seeing things in the world, in the environment, in reality that aren't real, and they're distorting them. They can also have misperceptions in the form of sensory stimuli that are elaborated into hallucinations, like hearing voices or seeing things or feeling things in their body. The origins of the illness actually begin at conception. The vulnerability to develop it is genetic and constitutional, meaning that it's in the organic substance of your body and specifically your brain.
Okay. And are there gender differences in schizophrenia?
There are gender differences, but not in frequency. In other words, that females and males are equally susceptible to developing the illness. However, the course of the illness is somewhat different, and this has been consistently found to be the case, which is that females tend to have a slightly later onset of the illness by 2 to 5 years. Also, they generally respond to treatment better than males do. And their symptoms and course of illness tends to be less severe than men. Also, if you examine brain structure using MRI or some imaging analysis, their degree at the beginning of their illness of any type of anatomic abnormalities is less. Now, let me just qualify that by saying that there is a proportion of women who develop schizophrenia, let's say 10, maximally 15%, that do not enjoy this gender advantage. In other words, they have a more severe form of the illness, and their age of onset difference is the same as males, and their response to treatment is actually poor, and they have the same degree of anatomic abnormalities. But by and large, females have a better prognosis.
Females responding better to treatment. Is there a reason essentially for that? Has there been research or is there evidence to explain why that is the case?
Well, women are just better at everything. And but the main sort of hypothesis as to what the reason is that there are hormonal factors that are involved. So estrogen actually plays a salutary role in mitigating the effects of the illness in the brain.
Interesting. So as a parent, seeing the signs potentially of a child with schizophrenia, I mean, given that symptoms may just look like common problems that a teenager may face during adolescence, how can one distinguish between, just a troublesome teenager and the onset of schizophrenia or the early development of schizophrenia?
Yeah, that's a great question. Let me answer it this way, because it really hinges on how one makes a diagnosis of an illness. When medicine first began getting scientific, all diseases were diagnosed the same way, meaning observing the patient and having the patient describe whatever discomfort they may be experiencing. So a condition like epilepsy was called falling sickness because when you had a seizure, you fell to the ground. Congestive heart failure was called dropsy. But then technology was applied, and we had an EKG to diagnose a heart attack. We had an EEG to diagnose seizures. Um, Psychiatry and mental illness has not moved beyond this first observational stage, meaning that all diagnoses are based on observing the person and
Right.
understanding the history, and then having their subjective report of how they're feeling. And uh, this is not a very precise and definitive way to make a diagnosis. So when you say somebody going through adolescence and they begin to have some type of behavioral changes, how do you know it's not just their maturational process, them finding themselves, them going through the process of transitioning from somebody who's a dependent child to an independent adult?
Yeah.
Um, and it's very difficult, especially in our modern societies when there's social media and kids are given so much freedom. So the first thing I would advise parents to do is look at their family history. As painful as that may seem like it would be, people say, "Oh, we don't have any mental illness in our family. Nobody has gotten sick. It's really rare." Well, that's not true. If you look at the statistics, it's very common, and most families have to be affected in some way, even if it hasn't been recognized. The second thing is that the changes, if they're severe or if they're progressive, meaning they begin to exhibit some kind of change, they stop lose interest in their usual things they like to do, or their friends, or they stop, they're more isolative. If that progresses or is sustained, then I encourage people to err on the side of being safe by getting an evaluation early. It's likely that if you go to your primary care doctor or a mental health professional, they may not be able to say anything conclusive, but you begin a process of watchful waiting to see if the condition worsens. So it's sort of like having a bad hair day. In other words, kids can have changes in their moodiness and their interests and so forth, but is it something that is sustained and then worsens that really it separates just going through different changes from something that's the early warning signs of an imminent mental illness? Eventually, what happens is that the disturbances in their thinking or the fluctuation in their interests and their emotions crystallizes into psychotic symptoms, which is false beliefs
Right.
or false perceptions. People are ganging up on me. What do you mean they're ganging up on me? Nobody's doing anything. Somebody's trying to spy on me, or if they join
Yeah.
cults, things of that sort. The other thing that's a real no-no, a real concern is recreational drugs. Recreational drugs can produce behavioral changes, and in vulnerable individuals who have a certain susceptibility to the illness, it can provoke or accelerate the onset. And it's not all recreational drugs. It's drugs like amphetamine, stimulants, cannabis, ketamine, special K, and
Yes.
psychedelics that you have to worry about.
We will definitely come to that point of substance abuse and the correlation with the development of schizophrenia in a little while. But I wanted to go back to the idea of, can you talk us through the gene-environment interactions, as you previously brushed upon earlier, that makes schizophrenia more likely?
Well, genetics has a lot to do with health and disease susceptibility in all respects. And most people, when they think about genetic genes involved in illness, they think of the autosomal dominant monogenic diseases like Huntington's disease or cystic fibrosis or Down syndrome. This is like one gene mutation, and you're definitely going to get the illness.
Yes.
But the majority of disorders that have a genetic contribution are called multigenic or polygenic, meaning it's not one gene, it's multiple genes. And these genes don't
Right.
definitively cause the person to have the illness. they induce or they confer a possibility or probability that they'll get the illness. So, for example, two polygenic or multigenic disorders like schizophrenia are diabetes, type 2 diabetes, and hypertensive cardiovascular disease. So if you're somebody who is very conscious about their weight, their fitness, they exercise, they watch their diet, they don't smoke, their likelihood of developing this, even if they have a family history of it and some genetic susceptibility, is substantially less and may never, ever develop these conditions. The other hand, if they become like a chef or they're a bon vivant and they like to enjoy life and don't really care about keeping fit, their likelihood is increased. So schizophrenia is like this, and there's a contribution. We can't say if it's 50-50 or what the percentage is, but a good way of looking at it is if in your family there is an individual that has schizophrenia, is diagnosed with schizophrenia, then the degree to which you are close to that person, meaning a sister or brother, a cousin, first cousin, a second cousin, an aunt or uncle, that will confer the increased possibility of you developing the illness. And the interesting phenomenon is that if you take identical twins and one develops schizophrenia, the likelihood of the other developing it is only 50%, which is high, but it's not 100%. So therein
Okay.
lies the environmental contribution.
Absolutely. It's multifactorial. But are there genetic tests available to predict one's likelihood of developing schizophrenia?
Not yet. I mean, there are tests that are being done, but they're not really incorporated into the clinical standard of care. And the reason is that, well, there's a couple of reasons. First, there are many genes that contribute. So when I say polygenic or multigenic, what does that mean? 5, 10, 20, 50, 100? With schizophrenia, slightly over 100 genes have been implicated in association with developing the illness.
Okay.
And their relative contributions is not entirely clear. But because of that, we are able to develop what's called a polygenic risk score. So if somebody really is concerned and really wants to learn everything they can about the possibility of their family member or their child having the illness, they can obtain genotyping, whole genome sequencing. It's now become relatively affordable. And from that can be derived a polygenic risk score. The problem is that that's not anything which is going to be precisely definitive. It can be informative, but it's really not correct. And what it does is it may be a false positive. It may alarm you and alarm your family member, but unnecessarily because they may never go on to develop the condition. But on the other hand, being forewarned is forearmed, and that means you just need to lead a more careful life and avoid certain things that can precipitate the onset of schizophrenia.
Of course. I mean, diet and lifestyle play a very important part, I'm sure, to help prevent or at least reduce the risk of developing schizophrenia. We will talk about that in a short while. But when schizophrenia is active, Dr. Lieberman, what are the symptoms that a person may experience? The positive and the negative symptoms.
What brings the illness to medical professionals' attention, or the family prompts the family to seek professional attention, are usually what are called the positive or psychotic symptoms of the illness. And those are a disturbance in someone's thought process, meaning that they're making misjudgments on how they're viewing reality. So
Yes.
they're perceiving things in a way that leads them to analyze information and come to opinions or conclusions about external reality that's at variance with what most people would say is happening. And these take the form of usually of delusions, which are fixed false beliefs. And one of the real, I think, deceptive aspects of the illness is that when a young person, begins complaining or talking about how so-and-so is conspiring against them or doing things on the internet, or that they have special powers that they can communicate with God or with supernatural beings about. Um, they have complete conviction. They cannot be talked out of it. You can give them all the evidence to disprove this, but it's ineffective. The other thing that happens is that their ability to concentrate. So if they're in school, their ability
Yes.
to function will be compromised. And they also may experience, in the form of these perceptual disturbances, taking the form of hallucinations. And although it can affect any one of the five sense modalities, the most common is auditory voices. And
Okay.
people will have voices talking to them, and the voices can vary. They can just be a silent, neutral commentary. Oh, Jeff is sitting here talking to somebody on a computer, but he's also drinking this glass of water. Or it can be much more menacing. It can say, you're a horrible person. You really
Yeah.
are somebody that's cursed. You really should do bad things to people because you're so bad, and that's what you're. And these are called command hallucinations, which are quite ominous. And then the other thing is that it causes a person's train of thought to be disorganized. And the most extreme, the way this is manifested is when they talk to you, their speech is not coherent. Um,
Right.
there's several things that make schizophrenia such a tragic and terrible disease. One is that it strikes you when you're coming into the prime of your life. Okay, you're just in the full bloom of youth and ready to take on the world. Second is that it has three symptom dimensions. The psychotic symptoms are the ones that get the most attention, which we've just talked about. But then there are
Yeah.
also the negative symptoms and then cognitive symptoms. Now, negative
Yes.
symptoms are kind of the opposite of psychotic symptoms. Psychotic symptoms are overactivity of parts of the brain that cause these aberrations in thinking and perception.
Right. Right.
Negative symptoms is the absence of normal mentative functions. So, for example, you lose interest in things. You lose the ability to experience pleasure, like somebody loves to play board games or loves to play sports. They don't derive pleasure. This is called anhedonia. Their emotional vibrance is muted. So instead of being active and very gregarious and happy or talking a lot, and they become much more silent, introverted, quiet. And it's like they begin to sort of lose their vibrance of their personality, and they become sort of different people. And then the cognitive symptoms reflect the ability for a person to do what we all do in the course of our daily lives, is figure out, what do we have to do that day? How do we do the domestic things? If we're involved in some professional activity, we have to make judgments. We have to analyze informations. We have to calculate things. We have to remember. Interestingly, or not so interestingly, but unfortunately, the treatments that we have pretty much predominantly only focus on the psychosis.
Yes.
And they don't really have much in the way of therapeutic effects on negative symptoms or cognition. Cognition is a little more complicated, and if you'd like, I'll go into that now or at a later point. But the and the reason why it's important historically and in terms of one's management of people with the illness. In the 19th century, medicine was just beginning to differentiate into specialties. And people don't, would be surprised to know that the actual very first specialty to emerge was the brain doctors, psychiatrists, and neurologists. Prior to the 19th century, physicians were like tradesmen because it was a pretty
Yes.
messy job. And they were curers and carvers, surgeons and physicians. They're also midwives. But what happened was is that there was no real, there were not real precisely defined diagnoses like we have now. There was melancholia, which was the equivalent of depression. There was manic depressive illness. There was uh, schizophrenia, insanity. There was idiocy, mental retardation. But in the latter part of the 19th century, German psychiatrist Emil Kraepelin defined schizophrenia for the first time as a distinct entity. And he called it not schizophrenia, he called it dementia praecox. So dementia, obviously cognitive impairment,
Yeah.
and precox, because dementia was usually associated with old age, and you had senile dementia. This was dementia occurring to people in their 20s, so he called it dementia precox. And that's because he noticed that when people got sick, and of course there were no treatments then, they had this gradual decline in their intellectual faculties where they came to a point where they were kind of zombie-like. Unfortunately, a colleague of his, Eugen Breuer, several years later, changed the focus to the symptoms of the illness and renamed it schizophrenia. But the process and what makes schizophrenia such a horrible illness is that if it's not treated promptly and effectively, it leads to an inexorable progression, which erodes a person's intellectual capacity. And at this point, when that happens, it's pretty much irreversible. Now, it's not like a dementia such as Alzheimer's disease where you die, but you become permanently impaired. So you're disabled, you become a mental invalid.
As you mentioned, early treatment is key. So obviously the audience would be interested to know more about the treatment options that are available and how effective are the antipsychotic drugs for this disorder.
Well, you've asked a question that's really a it's an unpleasant one to have to answer because first of all, there's a general skepticism about the effectiveness of treatments for schizophrenia. People think that it's a terrible illness and there's nothing that you can do about it. Well, that's absolutely not true. On the other hand, our and I don't know how it is in every country, or in Lebanon particularly, but I know how it is in the United States, Western Europe, and Asia. You have a standard of medical care, health care that's provided to the population for all diseases. And when it comes to mental illness, that standard of care is lower. It's really a deficient level of care that's provided. So what could be done to help people with schizophrenia and other mental illnesses is just not done because the treatments are not made available and accessible. So that's really a health policy issue. My personal opinion is that this is really a human rights violation.
Yeah.
Because conservatively speaking, you have worldwide over 1 billion people who suffer from a serious mental illness. In the United States, it's about 70 million people. And
Yeah.
if the governments are responsible, if the government, what are the rights of people in a specific country, and what's the government's responsibility? Well, it's to protect them, to provide education, infrastructure. Well, healthcare, presumably. We're not doing it for mental illness. So the problem is that treatments are highly effective, but only if used strategically and in the right combination. And what I mean by that is we know that the longer a person is actively, once you develop the symptoms and the diagnosis can be made of a psychotic disorder, likely schizophrenia, the longer that person remains in that state, the less responsive they'll be to treatment. And then subsequently, if they've recovered, they've remitted, they've tried to resume their lives, but they have relapses, then the more relapses they have, similarly, there'll be a greater potential for this progression. So there's a nursery rhyme that I use to analogize it to about Humpty Dumpty. Humpty Dumpty is an egg and he's sitting on a wall and Humpty Dumpty falls and he cracks and can't be put back together. And it's really an analogy that reflects the fact that you can prevent schizophrenia from having its progressive, disabling effects, but you can't restore a person after they've developed. So the key is early detection intervention. And what that begins with really is medication. Medication must be introduced as soon as a diagnosis can be established and definitive way. But then, and this was a great fallacy that we learned a painful lesson from, it's not simply a matter of giving a patient a pill or an injection, a long-acting medication.
Yeah.
Think of psychosis as like, it's not a stroke, but it's like a brain attack. Your brain goes off in terms of its the normal neurochemical equilibrium that exists and you function with on a daily basis. You go off as if somebody gave you a mind-altering drug like LSD or phencyclidine, PCP, angel dust, your brain would go off because pharmacologically it's been adulterated. In people with schizophrenia, it goes off spontaneously, and medication helps to restore it. But when you measure recovery by the psychosis subsiding, it doesn't mean that the brain's fully recovered. It's like if you sprain an ankle or you
Yes.
break a bone, you have to rehab. So what that means is that when somebody has their onset of illness, they're treated, their symptoms subside, they want to resume their lives socially, educationally, they often need support and they need what's called psychosocial services. The term for this model of care is called coordinated specialty care or team-based multidisciplinary care because they often need like somebody to be a coach for them, to help them get back on their feet and know how to navigate through the normal social situations. They may need some support in learning how to study again, getting back into school. So that's called supported education. If they're working, they may need similarly somebody to run interference for them in the workplace and explain, Johnny or Susie is just getting back into condition where they can resume their work. So be a little bit more patient at this point. Um, Oftentimes people have experienced because they said, here I was, strapping young 18, 19, 20-year-old, and this happens. And they become demoralized and they even think of suicide. So there needs to be, suicide monitoring. And if they've been abusing drugs, there needs to be substance abuse. So, and then there's also something called psychoeducation, which means most people have no idea what schizophrenia is, and most families don't. And when their son or daughter becomes ill and they get better, they go, oh, thank God, our child is better. Now we can just go back to what we were doing. So, no, you have to understand this is a lifelong possible illness that can recur and recur and recur. So you've now learned that you've just been diagnosed with something like type 1 diabetes that you have to take care of on an ongoing basis. So psychoeducation is basically a process where the patient and their family is informed about what this illness is all about and what they have to be mindful of in order to make sure that it doesn't destroy their loved one's life.
It's always very interesting to see it from many different perspectives, and certainly, the cultural element plays a big part because I do know from here, from this side of the world, things like schizophrenia was often regarded as a taboo issue or something that could not be discussed so openly and comfortably. Thankfully, in the way that we're living now, things have gotten much, much better. There are more conversations going. There's more psychoeducation. But it must be quite frustrating that, as you mentioned before about those who are affected need to have access, to facilities, to healthcare, to drugs, etc. But I'm sure that's not the case in many parts of the world whereby, they're living in underdeveloped conditions or conflict zones. So how accurate is the data? How frustrated is the research community in wanting to access those areas whereby it would be more difficult for you to gain access to? But obviously, the numbers and the results would probably be quite different in comparison to the more developed countries in which you are conducting the research.
Yeah, that's a great question. And the way I would put it is that, there's the opening line of the of I'm trying to think of whose novel. I think Dickens was. It was the best of times and it was the worst of times. And that's the
Yeah.
case with mental illness. You know, one could say, if you look at the history of mental illness, which I've studied and written two books about, it's something that's been hiding in plain sight and pretty much neglected or vilified by society throughout history. In the modern era, it's accepted as an illness, but it's still not gotten the proper attention. And what the public sees is really what I would call the tip of the iceberg. In other words, if you talk about all different types of mental illness, not just schizophrenia, but depression, trauma, trauma-induced disorders, anxiety disorders, substance abuse. Um, uh, let's put it this way. If you take and you conservatively define the population of the world who has some form of a mental illness, over half of them receive no treatment. So over half of them receive no treatment. Um, and part of it has to do with lack of awareness and recognition. Part of it has to do with shame and stigma. They don't want to be identified as needing mental health care. And part of it has to do with the lack of access to mental health care. But I mean, think about it. You know, if you talk about heart disease, cancer, endocrine disorders, it's not perfect, but it's not over half are not receiving any care. Um, so the issue is, one, there's this perceptual or this reputational or attitudinal issue about mental illness. Then secondly, there's a limited awareness. You know, everybody knows what a heart attack is, but not everybody knows what a mental illness is. And then the reality is that it's not a priority for governments. So in the United States, people say, "Oh, it's better now than it's ever been," and it's particularly after COVID. You know, in COVID, we really had to focus on mental wellness, like loneliness and isolation. Well, that's true, but that's not serious mental illness. You know, wellness is something that we all aspire to, just like fitness, physical fitness. So this is I'm calling this, and I don't think I'm exaggerating, a human rights violation, or in our country, a civil rights violation, where a standard of care is being withheld from a substantial portion of the population. And even so my department was the leading or one of the top 3 departments in the country for the 20 years that I was chair of the department. But I couldn't tell people that if you come to our place, we've got everything that the level of our knowledge about these illnesses uh, 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 enables us to do for treatment. We simply didn't have it. Now you say, well, why is that? Because the hospital has to make an allocation of space, of resources to support those services, which is much less profitable than having surgeries or having radiologic procedures or
Absolutely.
having any type of procedural specialties. In addition, the insurance benefits that pay for most people's health care, whether it's national government-sponsored health care or whether it's private insurance, the benefits in terms of what the policy or what the insurance will pay for, even if you did find those services, is not enough to cover it. Is not enough to cover it. So people have to pay out of pocket. And if you go on the internet and you go into some of the chat groups of family members of people with mental illness, and particularly schizophrenia, and you read them, it is heartbreaking. It is heartbreaking. I mean, there's just thousands of these that are just out there, and you say, how could this possibly be happening? And this is in America, which in many places it's much worse, in Asia particularly, or Africa.
Sure.
But how can this be happening? So I refer to this as hiding in plain sight, or a denial of the humanity and the legitimacy of the illnesses that afflict a certain number of people. And it's like there's a collective a collective delusion or collective, illusion that that's been inculcated in the population. Because how could we not see it? In the United States, what the average person sees about this and comes to their attention is homelessness, violence that's perpetrated by individuals who are mentally ill, like taking a gun and just shooting randomly strangers, pushing somebody onto the railroad or subway tracks, but for no reason other than the voices are telling them to. Do you know that there's 40% of the people in our jails, in our prisons, are people with mental illness? 40%.
Yep.
And 40% of the homeless people are people with mental illness. So this is what comes to the public's attention. Also, suicide, because these are glaring things that happen. Addiction. So it's really a global problem, varies from country to country. And the only solution, I really think, is that there needs to be what I call a macro solution. It has to be orchestrated by state or regional or national or federal governments. But to do that, there has to be an effort to change the mindset of politicians. Now, try to affect something in our political systems. Well, one of the big problems to start, particularly in the United States, is there are certain voting constituencies or voting blocks, like women's rights, education, birth control, etc. There's no mental illness voting block. So, the politicians just have to basically play they have to gauge their chances of election, and very few politicians will make mental illness a signature issue. Patrick Kennedy, who's a good friend of mine, did. A number of people did in the past, but no one currently is. And I used to, say in a way that sounded like I was being cruel, was the best thing that can happen for the future of mental health care is for a head of state's son or daughter to develop a mental illness, because that'll focus attention on it and make it a priority.
Absolutely.
So the bottom line is that if you have a disease like amyotrophic lateral sclerosis, or certain really severe forms of cancer, like ovarian or pancreatic cancer, or if you have a genetic disease like Huntington's disease, there's nothing that can be done, no matter how much money you have, how well connected you are, until there's a scientific breakthrough that changes the way people are treated. With schizophrenia, that's not the case. We've got the tools to do it. We know that if you have an early identification process and identify people soon after they develop the symptoms, and then after they're treated to remission, which 75 to 80% will in their first episode, and sustain them with support so that they don't have relapses, they basically have beaten the illness. But that happens in some cases, but it's really much rarer and is the exception as opposed to the rule. And every time that a person gets ill and doesn't get this care, it's like there's a window of opportunity that slips away.
Absolutely. It isn't at the forefront of government policy, unfortunately, and there has to be stronger advocacy to raise collective awareness, and for there to be a stronger push, I think, in communities to, just make this a much more important issue amongst us. We're living in a time whereby, mental health disorders are very much in the mainstream, whether it be, in the public eye or, through the information that we have access to. But like you mentioned very wisely, there isn't enough being done at the moment, I think. And especially with the misinformation that is presented about specifically schizophrenia in the media, it's very frightening, actually, to see how much false perception of the disease lies within the landscape of digital media. So we will definitely talk about stigma towards the end of this interview, but I would like to go back to the neurobiological aspect. So synaptic dysfunction is a key pathophysiological factor in schizophrenia. So can you explain to us how this plays a role in the symptoms of schizophrenia?
Your statement really hits the exactly this target of where the illness, where's the mischief in the brain, and it's at the synapse. So the way the human brain develops, first the sperm and the egg fertilize and create an embryo, and it develops over a 9-month gestation period and is born and is an infant. By the time you're 5 years old, you have your brain is almost full size, and you have all the neurons you're ever going to have, because the brain is the only organ that doesn't have stem cells that produces new cells throughout your life. So by the time you're 5, you've got all the neurons you're ever going to have. What changes after that is the synapses that are formed by the branches of the neuron and the connections between those that form neural circuits. And the neural circuits have little gaps between the axons of one neuron and the dendrites, which are receiving the signal of the next neuron in the circuit. And these little gaps are called synapses. And the way an impulse, a brain electrical activity is transmitted from one cell to the next across the synapses by a neurochemical bridge. In other words, the end of the transmitting neuron releases a chemical called a neurotransmitter, which then floods the synapse, and then it binds to certain proteins on the membrane of the next neuron, which are called receptors. And so even though the brain's fully formed at age 5 in terms of number of cells and size, its circuitry and its connectivity continues to evolve and change all the way into adolescence. And once you're in adolescence, the number of these synapses that have been affected begins to be pruned or reduced, because by that time, the brain, which has overexpressed these in order to allow young children to learn, they've now had enough time to be educated, to have experience in the world, and only the ones that are hardwired by experience-depending learning are retained. What happens in schizophrenia, though, is that the normal controls or homeostatic mechanisms that regulate the activity in these circuits in terms of the synaptic transmission of impulses begins to become more vulnerable to destabilization. So in the course of everyone's life, you've got challenges that happen. You have good, happy times, you have sad times, you have stressful times. So your brain is built, like your body is built, to handle these extreme changes. And they can go one way, but they always can re-equilibrate and come back to a standard level of normality or an equilibrium. What happens in schizophrenia is that they're not able to recorrect. And the specific circuits that go off are ones that are controlled by 2 neurotransmitters, dopamine and glutamate. And once something prompts them to sort of lose control, it can be stress, it can be, they were partying and they smoked some marijuana, or they took some other drug, or it can just spontaneously occur. It causes the induction of the symptoms that we were talking about before, the changes in your thinking and your perception and your emotion regulation. If that's not stopped with medication, meaning the normal equilibrium is restored, then there's a possibility that what's this initially a chemical dysregulation that results in the ablation of the synapse, meaning there's too much neurotransmitter and it becomes toxic at a certain level and causes the synapse to die and be eliminated. And that's what really is what produces the progression of the illness over time if that happens. So when we talk about schizophrenia in terms of the histopathology of the brain or neuropathology of brain, it's really a disease of synaptic dysfunction, or it's a disease of connectivity. And so individuals that remain psychotic or have repeated episodes that aren't treated soon enough so that the normal equilibrium is reestablished, they begin to lose these synapses, these branches of the neurons, and the gray matter in their brain actually shrinks. They experience this degree of this atrophy. So what's the good news is that that process can be prevented by what we were talking about before, the early detection, intervention, and the support team that keeps the patient on track and doesn't allow for them to experience a relapse. But unfortunately, that isn't the case for most patients, and they do experience recurrences, which I actually want to say something more about. And once they do, they descend down what I'll call the slippery slope of progression of the disease. This is where two things come in that are relevant. One is it makes treating people with schizophrenia difficult and more difficult than it is for many other illnesses. So when you're young, you think you're invulnerable. You think nothing can hurt you and you're fine, and you have this kind of ebullient bravado that you can take on the world for the most part. When you get sick with first episode of schizophrenia and you recover from that, it's hard for someone, especially if they were a successful and popular individual in their social class, in their school, and whatever, the social network they were in, to accept the fact that they've had this. And so there's this degree of denial. And the other thing that is very difficult is there's actually an effect of the illness that causes people to not recognize that they were sick.
Okay.
In other words, they don't know what happened to them, but they don't attribute it to an illness. And they're not going to, say, "Oh God, I really was out of my mind. There must be something wrong." There's a lack of awareness, and the term for that is called anosognomia. And as a result of that, they don't necessarily think they were sick, and they don't necessarily think they need treatment. So they may not want to take treatment and will not adhere to it unless there's some added encouragement or long-acting administration of a form of medication. So because of this, the early phase of the illness, by early phase, I'll say first 5 years, is critical because that's the time when the individual has the most to lose. And by lose, I'm talking about the term that's a neurobiological term is called neuropill, which refers to not the cell bodies of neurons, but the branches of neurons, the dendrites and the synapses. If they're not treated early and they don't adhere to the recommended aftercare, and they experience recurrent episodes of this, which they will. There's very, very few, if any, individuals who are one and done with the onset of psychotic psychosis from schizophrenia. And anybody who says that there is not up on their research. Is that that's when they have the most to lose, and and by lose, it's exactly what you were referring to, the synaptic dimensions of their brain.
I'm really interested to just touch upon the topic of substance use. So, through the research, we know that substance use disorder is much higher in those who experience schizophrenia. Is that related to dopamine dysregulation? Is there a connection there in those who have schizophrenia?
Well, substance abuse occurs, I think, in two ways or two motivating factors. One is that once people are sick with the illness, and usually it's occurring not necessarily at the beginning of the illness, although it can occur anytime, they self-medicate because they're not feeling well. Their symptoms
Okay.
are called dysphoric. They're not happy symptoms, and they're not in a pleasant state of mind, and they self-medicate. When the most common form of self-medication is smoking, nicotine. But the other way in which substance abuse figures in is that because youth use recreational drugs now very commonly, and some of these are really provocative or psychotogenic, meaning that they induce psychosis. Uh, and the ones, and I'm not encouraging people to use the safe ones because they're not good in other ways, but there's certain drugs that are worse. If you tell a young kid, oh, you can
Yes.
never take a drink of alcohol, you can never take any kind of recreational drug, that's going to be a hard thing for them to accept. But if you tell them, well, look, there's certain drugs that have all recreational are not good for you, but there are certain ones that are worse. So at the top of the list is phencyclidine and ketamine, and then methamphetamine, and then any other stimulant, and then cannabis, and then
Yeah.
psychedelics. Uh, so these can induce in a vulnerable individual the illness. Now, there's one other aspect of it that I'd like to mention, which is, and this goes back to when we were discussing how do parents recognize it in their adolescent children, and that's the difficulty of reliable diagnosis. So, because psychiatry makes diagnoses of mental illnesses based on observation, behavior, and reporting of mental states by the individual, there's ways in which the diagnosis, is not completely precise. And there's three different categories of causes of the illness, that can produce a symptom picture that looks like schizophrenia. The first is, idiopathic schizophrenia, which occurs in individuals who have a genetic or constitutional vulnerability and develop it. But the second are what are called phenocopies. So a phenocopy is someone who has more of an environmental or totally an environmental cause as opposed to low genetic susceptibility, no family history. Even if you genotype them, you wouldn't find anything. But so how do they get it? Well, there's a couple of ways. So a phenocopy is basically something which mimics the naturally occurring form of the illness. And a form that's been discovered recently is called limbic encephalitis or autoimmune encephalitis. So there's a condition in which the body produces antibodies, which like it does with many autoimmune diseases. That we have lupus and fibromyalgia and Sjogren's syndrome, et cetera. But in this case, the antibody has affinity for certain proteins in the brain, and specifically for a protein that forms a receptor that recognizes the neurotransmitter glutamate. And so this condition looks like schizophrenia, but it's an autoimmune disorder, and it doesn't respond to antipsychotic medication. A journalist wrote a book about this a few years ago called My Brain on Fire, when she was hospitalized, but was incorrectly diagnosed and then finally determined to have had limbic encephalitis. Another phenocopy is, it used to be thought that taking recreational drugs couldn't cause schizophrenia. It could provoke it in vulnerable people, but it couldn't cause it in somebody who was not susceptible. That's not true. We've learned really, and from many sets of data since then, that if you abuse certain drugs on a repeated basis, and particularly at vulnerable ages, young ages, you can induce the symptoms of schizophrenia, and they won't go away even if you stop the causal substance. So it's the difference between somebody having a toxic psychosis
Yes.
and having a persisting psychotic disorder. So this has been the case. I mean, this was really learned from the Japanese post-World War II when their economy was devastated, and as they were trying to rebuild it, the factory workers were fed methamphetamine, and they had a huge epidemic of psychotic disorders that developed as a result of that. In the United States, it occurred with the PCP or angel dust epidemic in the 1980s. So if people would take methamphetamine or angel dust repeatedly for some period of time, this could wreck their brain and cause them to be persistently psychotic and look like schizophrenia. And the third thing now is cannabis.
Yes.
Since cannabis has been legalized and the potency has gone up, and young people are starting to smoke cannabis at ages 13, 14, 15, and they smoke daily. And we're seeing enormous increase in the numbers of paranoid psychoses. And the terrible thing is that even if they stop, it doesn't necessarily remit. It can be persistent. So we're
Persistent.
seeing,
Yeah.
and this is how public policy is not does not serve the public health interest. Um, states are legalizing these recreational substances. They get tax revenues. They appear to be satisfying public demand,
Yes.
but in this vulnerable population, they're causing increased rates of these types of disorders. And I'm not sure exactly when it's going to stop. I mean, it's a little bit like prohibition was in the 1920s, where the temperance movements, lobbied for the prohibition of alcohol. Well, that didn't last long. But I'm not sure how this is going to play out. But if a family wants to be as careful and protective and vigilant as they can, particularly if they have a family history,
Yeah.
then there needs to be increased surveillance and increased awareness about the potential for these drugs to produce this onset of illness, either by themselves or in inducing it in vulnerable people.
So is it right to say, perhaps it's not, that those who take on substances, who have, an addiction, are more treatment resistant, or is that not the case?
Well, if you have a genetic predisposition or vulnerability, and your use of recreational drugs precipitates the onset of your illness, that should not reduce your likelihood of being responsive to treatment. However,
Okay.
um, if your illness is induced by your heavy use of those drugs,
Yes.
medication is much less effective.
Okay.
Now, the other thing is, though, going back to the first example of somebody who has
Yes.
the predisposition and goes to a party and takes this drug, and all of a sudden has kind of an exacerbation of their low level symptoms, and they're treated and they stabilize, but then they go on to continue to use the recreational drugs, and have further episodes, then they'll become less resistant. So that raises a good point, Fay. Let me just mention it quickly. People
Yes.
talk about, do the drugs work? Okay, how
Yeah.
effective are they? The answer is they're highly effective. Um,
Absolutely.
in first episode patients who are well diagnosed, the response rate in terms of recovery, symptom remission, ability to move on with their life should be between 75 and 80%. Okay. Um, there are 15% of people who, even at that early phase, don't get better. And that's what I was referring to before when we talked about the gender differences of this more severe variant,
Yes.
that don't respond to treatment. Um, but that 15% is much less than if you go to any kind of clinic and you say, how many of your people with schizophrenia have gotten fully recovered from treatment? They'll say, oh, very few, 30%, maybe 20%, meaning that 60, 70, or 80% have been only partially responsive to treatment or not responsive to treatment. So that number, 60, 70, 80 versus the 15% in the first episode, what's the difference? The difference is that the 15% that have the severe form of the illness were sort of born with that. The others developed the treatment resistance in the course of their illness by virtue of the repeated episodes they had. So they started out in their first episode as being able to achieve a full recovery for the most part, symptom remission. But over the course of the illness, because of the fact that treatment wasn't continuous, either they were non-adherent or treatment wasn't provided, then they developed treatment resistance. So that's where that occurs. So when people say these drugs don't work, they're toxic, that's just not true.
But that's also it's part of a combination therapy, is it not? So one would have medication alongside another form of therapy, perhaps CBT. So this holistic, I guess, one has to emphasize the importance of taking a holistic approach as well when addressing a mental health disorder. Do you think that message is being carried through? Do you think we're focusing a lot on medication and not enough about one's lifestyle?
Absolutely. Absolutely. I mean, I think, medication just from the beginning when psychotropic drugs were first discovered in the 1950s, people thought, oh, just all we have to do is give people a pill and they'll get better. Well, that may be the case for some conditions like depression, but it certainly isn't for schizophrenia. You need to have this multidisciplinary team-based approach, and you need to have wraparound services. You need to basically you need to really. It used to be that the number of providers in terms of different types of specialists, social workers, psychologists, therapists, substance abuse counselors, these were reserved for people who were already ill for 10, 15, 20 years in the chronic stages of the illness. Well, it's the people who are just getting sick that are really the ones at greatest risk. And so the whole idea of early detection intervention led to recognition that it needs to be multidisciplinary team-based approach, because these kids, one, they think they're invulnerable. Two, they don't think they were ill, and they don't necessarily, they want to put this behind them as quickly as they can and pretend it never happened. But that's to their detriment, and it's to society's detriment. And the problem is that this model of care is just not available, and it needs to be.
The idea of putting more focus on one's way of life, what they eat, their diet, their routine, is really key. And something that I wanted to mention is the idea of inflammation in the system, and how that contributes to many chronic diseases. And also, it's been shown that inflammation does in fact contribute to brain alterations seen in schizophrenia. So can you talk us through, in a nutshell, it's a very big topic, but can you talk us through the link between chronic inflammation, diet, and schizophrenia?
Well, Fay, you've opened up a broad area, or a number of areas which intersect in schizophrenia and any chronic illness. That I'm trying to think how to explain this succinctly. So first of all, people generally speaking have a primary care physician. Somebody you go to is your GP, your primary care physician, and if you have problem with your knee hurting, or if you're having shortness of breath, or if you have some type of rash, or you'll go to see them and you don't have an illness, you just have something that's bothering you. Well, it happens also with the brain and the mind. So, okay, let me give you an interesting point that most people would never have thought of. Your body has 78 organs in it, 37 trillion cells. The cells are differentiated into the specific organ types or tissue types. Your brain is 3 pounds. Oh, I don't know how much you weigh, but like I weigh 180 pounds. So 3 pounds, 180 pounds, what percentage of that is my body weight? Not much. On the other hand, the brain consumes 20% of all the oxygen and all the glucose, all the energy substrates, because it's so important in terms of what it does. So you need to take care of your body and you need to take care of your brain.
Yes.
And that's uh, certainly not getting sick, or if you do get sick, getting treatment, but it's also just good hygiene, good lifestyle practices, good salutary behavior, fitness. Interesting example of that is cardiovascular disease was the biggest killer of middle-aged people in the 1950s by far. And then the president at the time, Dwight Eisenhower, had a heart attack, and that focused attention on heart disease. From 1955 to the end of the century, because of the focus on it, the morbidity mortality decreased by over 50%, over 50% within 50 years. And the biggest factors that contributed to it weren't just the statins and weren't just the angioplasties. It was lifestyle. It was stopping smoking. It was weight. It was nutrition. It was exercise. So what I'm saying is that mental wellness is a meritorious goal for healthcare, and everybody can benefit from it. And individuals with mental illness, suffer from the same kinds of issues that can threaten mental illness and non-mentally ill people. So there's an overlap here, which you're referring to. So
Yeah.
you could say that the lifestyle practices that you were alluding to are things that everyone would benefit from, including people with schizophrenia, even though people with schizophrenia would rarely be practicing those very much for the most part. And although I would say they're highly encouraged, if they're not taking medication and they're not getting this other, multi-specialty support, that's not going to, keep them stable. So there has to be kind of a pyramid, a tier of the
Yes.
most priority treatments. Okay, inflammation. Now, it's interesting because there's a new conceptual model that is emerging in the context of longevity science. So, what's longevity science? Well, humanity is, for millennia been searching for eternal youth and immortality, but it's all been magical thinking and snake oil up until the 21st century. I mean, a lot of people made a lot of money on BS, on complete,
Absolutely.
ineffective bad things. And you still see it. People go for these stem cells and hormones and various things that are completely fraudulent. But in the 21st century, when the genome was sequenced, there was a discovery of 7 genes, a family of 7 genes called the sirtuin genes. And these genes program the lifespan of every creature in the animal kingdom. So we as humans have a defined lifespan of 80, 90 years. Dogs are 14 or 18 years. If you're a fruit fly, it's 24 hours. Certain whales can live up to 400 years. Um, so there's a genetic maturational boundary that we have. I've been working with several companies on developing now, based on this science, anti-aging pharmaceuticals. Now you're thinking, well, what's this got to do with schizophrenia? Um, well, what this has done is it's introduced a concept of how to attack disease as well as prevent disease. So going back to again to the 19th century when medicine first became scientific, The idea was to see if you could find in post-mortem dissection of cadavers the hallmarks of the disease and relate them to the symptoms they had before they died, and then develop treatments that would try and address this pathology. And so from that, we got a whole variety of treatments, like antibiotics and insulin, techniques like hand washing and sterile technique, ultimately vaccines. And the idea in medicine was to be ever more precisely targeting the pathology of the disease. And the apotheosis of that was precision medicine. If you have the gene, you can say a person has a genetic signature within the syndrome of pneumonia or the syndrome of hypertension that they have, that you can be even more precise. Well, the discovery of longevity science meant you could do something else too. If you can develop treatments which mitigate aging, then this introduces in a middle-aged person or older the ability to have their cells functioning like that of a younger person. So you have a chronologic age. Your chronologic age is today's date minus your birthday. But you also have a biologic age. And your biologic age may be older or younger than your chronologic age. I'm happy to say that my biologic age is 15 years younger than my chronologic age, to the extent that these measurements are entirely valid. So the ability to develop pharmaceuticals that mitigate the aging produces an effect of improving the resilience of cells, which in concert with a disease-specific treatment can be beneficial. Okay, so now I'm coming to inflammation. So we have different diseases. Mental disease, where we have a neurochemical dysregulation. You have Alzheimer's disease, where you have toxic protein aggregations that kill cells. We have heart disease, which is related to atherosclerotic plaques developing. We have autoimmune diseases where antibodies against our own body are produced. So in between the healthy person who's aging and the person who has the disease, we have some pathologic conditions that are transdiagnostic. They occur in many conditions. Inflammation is one of them. Occurs in many diseases. Fibrosis is another, that after you have a disease, you can produce this kind of scarring effect, which hardens the nature of the tissue. Atrophy is a third. So you have this more intermediate generic pathological conditions. And what this really implicates or suggests is that in treating diseases, we can use a polytherapeutic or a polypharmacologic approach. We don't have to simply target the disease. We can try and target the underlying transdiagnostic pathology. So, for example, if you have schizophrenia and you're taking antipsychotic medication, why not take an anti-inflammatory? And if there are successful anti-aging medications that are progressed, depending on what they are, then those might be helpful. And I'll give you one example. So aging is basically a consequence of a maturational process. I mean, you can make aging worse just by not living well, but it's just something that's going to happen anyway. And a lot of the hallmarks of aging is changes in your body that occur, your muscle mass, your bone density, your stamina, your VO2 max. Why do these things occur? Well, because the 37 trillion cells in your body, and the 78 organs in your body, they're working 24/7, 24 hours a day, 7 days a week, constantly to keep things running. And over time, they become less efficient, less resilient, less able. And in one instance, for the anti-aging pharmaceuticals, the approach is to try and mitigate this aging process by increasing the cellular energetics that drive the work of your body's cells and organs. So all your organs are comprised of cells of different sorts. And the energy that enables the cells to do the work that they have to are little organelles inside cells called mitochondria. And these are factories that produce energy in the form of ATP, adenosine triphosphate. And the adenosine triphosphate is a substrate that's produced through this series of chemical reactions in the mitochondria. And there's one enzyme that's the rate limiting, it's the key, it's the rate limiting enzyme to the ability of mitochondria to produce ATP. And it's called NAD, nicotinamide adenine dinucleotide. Over time, this diminishes like so many of other things do. So if you can potentiate that by a booster or by enhancing it in some way, that increases the energy of the cells to be able to do the work. What that suggests is that one can take really a triple therapeutic approach. You can treat a disease. You can also treat the transdiagnostic and underlying pathology. And then you also can use these medications, which anybody who wants to try and age more slowly would be interested in taking. But in the case of increasing cellular energetics, they'll have a benefit in terms of combating the disease as well. So this is sort of a very long-winded way of answering your question. But since you asked, I wanted to introduce this because
Fascinating.
There's another angle that you'll maybe want to think about later for another program is the aging process and the diseases of aging, particularly in terms of brain health, because that's really going to be the key as we all, like my mother, bless her heart, she turned 101 in March.
God bless her.
And she still can talk your ear off and can be the life of the party and everything, but she's frail.
Yeah.
She uses a walker. She can't move around. So if we're going to be able to extend our life beyond what our previous genetically defined boundary was, we're going to have to sort of reorient ourselves so we're going to be able to live a high quality of life for as long as we live.
What advice, Dr. Lieberman, would you give to someone newly diagnosed with schizophrenia?
You have to basically, so people get bad news often, that really sets them back. It's harder when they're young than when they're older, but it's never good. But when you get a diagnosis of schizophrenia, you have to completely re-examine how you want to live your life in order to maximize your ability to overcome the what the illness is capable of doing. So as a friend of mine, was really a brilliant person, socially very popular, and he had a ski accident and became paraplegic in his late 20s. I mean, he had the world, it was his oyster and he could have done it. And how do you cope with that?
Yeah.
So in the case of schizophrenia, it's kind of that situation. But the good news is that you can. It's just that people aren't able to accept it or aren't given the necessary guidance that they need in order to be able to do so. So I've written two books for the public. One was called Shrinks, The Untold Story of Psychiatry, to try and demystify mental illness in psychiatry.
Nice.
And then the second is Malady of the Mind, Schizophrenia and the Path to Prevention. In that, I talk about, I think it's the first chapter, I talk about Jonah, who was the light of his family's, aspirations and hopes and everything, and was all these things going from, and he developed the illness and he recovered fully. And 5 years later, he was a shell of his former self and would never be the same. And so there has to be a recognition of the fact that they've encountered an illness that fortunately they can overcome, but they can't basically fight what's been accumulated as scientific knowledge and understanding of the illness and what needs to be done in order to limit its debilitating effects. And so there's kind of a humbling effect that occurs. You have to basically submit yourself to the knowledge that hopefully you're capable and compassionate and concerned physician or healthcare provider is providing to you, and follow it. And if you try and test it on your own, you can do that, but it's at your own peril. And the way that usually comes up is that you treat a first episode patient, they get better,
Yes.
and they say,
Yes.
when can I come off the medication? And you say, well, okay, why do you want to? Anyway, it comes down to this. You lay out two scenarios. One is that knowing what we know about this illness and its likelihood of recurrence and what the risks are and it's recurring, you can stay on a low maintenance dose on an indefinite basis with the accompanying necessary psychosocial supports as needed. Or if you want, we can try to taper and discontinue your medication and continue to follow you very closely in the event that symptoms recur, and if so, reintroduce medication. Most people want the latter, and some people don't even ask. They just go and take matters into their own hands, like Jonah in the book did. And but then what I do is, if they want to, if they ask me the question that I would ask any other doctor if I was taking my child to see them, and that you or your audience might bear in mind to ask if they're in similar situations, is, well, what would you do if it was your child, or what would you do if it was you?
Absolutely.
That sort of cuts through it. And don't give me all this statistics, just tell me what you would do. And I would remain on medication in a tolerable level of medication that was effective at preventing. We know the drugs suppress the symptoms, and we know they prevent their recurrence. So why would you want to stop? Well, I don't like taking drugs. Okay, well, if you had high blood pressure, would you take high blood pressure medication? Yeah. Well, if you had diabetes, would you take hypoglycemia? Yeah. What's the difference?
Yeah.
But the majority of people they think they can do it on their own, and God bless them if they can. But statistics are statistics. If you look at if there's anything that's completely proven in the studies measuring or monitoring the course of schizophrenia, it's that if you stop taking your antipsychotic medication after recovering from a first episode illness, you will have a recurrence. It may not be immediately, but within 5 years, it'll be 80%. Within 7 years, it'll be 90%. And it increases in rapidity and frequency after that if you go through this process of stopping medicine. You can stay on medicine also and have a relapse, but usually that's much less likely unless you're using recreational drugs or something.
Crucial information there, Dr. Lieberman. And finally, to what extent is community stigmatization of the disorder hindering the process of remission for those who are suffering from schizophrenia?
Oh, it's huge. It's huge. I hate the word stigma, but it's appropriate. Stigma is basically a combination of ignorance and prejudice.
Yeah.
And if somebody had COVID, or somebody had an episode of flu or broke their leg, and they come to school, or they hang out, and all their friends are asking about it, how do you feel, and so forth and so on. If you have a psychotic episode and you're returning to your prior social environment, you're not talking about it. And people are hesitant to ask you about it if they do have some inkling what's going on, because you're not sure what to say. You're not sure sort of if they've recovered, or if how they're going to act and so forth. So there's kind of a hesitancy and avoidance that occurs. An example that I use sometimes to show the effect of this, there was so about 40% of the mass violent shootings that occur in the United States are perpetrated by people who are untreated with schizophrenia. And one of them was a guy named Jared Loughner in Arizona who went this occasion to a location where Congresswoman Gabrielle Giffords was giving a speech, and he had no idea who she was or anything for any reason that was not psychotic other than just his delusions. But anyway, he shot several people, including her. She didn't die, but she had a shot her in the face, so her brain was irreparably damaged. So Loughner was 20 years old. He began getting symptomatic when he was, I was the consultant on the case, but it's in the public domain, so I can talk about it. He was beginning to get symptomatic when he was in high school, smoking weed. And he then sort of, after he graduated, he tried to join the Navy. He was rejected because of his mental status. He tried to get a job. He couldn't hold a job. So he's symptomatic already. His parents didn't know what to
Yes.
do. And he's trying to do something, but he's not able to. So he enrolls in a community college, and he's community college for about 6 months or so. And he's acting weird in class, and everybody's around him as the other students and the teachers and so forth. And after around 6 months, the dean calls him and his parents in, and they tell him that they've got to suspend him from school because the other students are afraid, or he's disruptive and so forth. So he gets suspended from school, and then he goes out and he buys a gun, and then he goes and shoots them. So the point is this: if he had been choking, or if he had all of a sudden unable to breathe, or if he had pain or had a seizure, people would rush to his side. They would call an ambulance, and they'd make sure he got medical attention. He's sitting there for like months acting weird, and nobody does anything. So the advice I give is that if you see something, say something, and don't be inhibited by somebody saying, "Oh, mind your own business." So if you see a friend, or you see an acquaintance, or you see a family member who's acting strange, acting different, seems something's amiss, don't think you're prying. Don't think you're pushing. I mean, the worst they can say is mind your own business. I'm perfectly fine or something. But so what? So if somebody would have identified him and got him directed towards the health service of the college or the university, might have been a different outcome. When I was at the University of Carolina, I was at the University of North Carolina in 1995. And shortly after I got there was a first-year law student who, smart kid, on his way to becoming a lawyer. He had developed schizophrenia a few months earlier, been treated for it, stopped his medication. Nobody either followed it up or, checked on him to see if he was still in treatment, and nobody noticed anything unusual in his behavior. Anyway, he goes up to the main street in the town of Chapel Hill, and he kills two people, completely random strangers, based on his hallucinations. When I interviewed him, he was had been remanded not guilty by reason of insanity to the state hospital. And when I interviewed him after he'd been treated, was completely lucid and coherent, and explained exactly what happened. And he'll never get out of the hospital. So, these things occur because, of our timidity about this, and our unwillingness to sort of ask what seem to be the awkward questions. So when somebody is, I'm saying, who's in this early phase of their illness and they want to get on with their life, I, sort of have you call it sort of like a come to Jesus discussion with them. But you have to realize what this moment, what the importance of this moment and what it holds with their family also. And it's your decision, but it's my responsibility to let you know what the reality of this illness is and what the possible outcomes are and what the best way to sort of manage those. And at this point, this is the best you could do. The good news is that these treatments are highly effective if we utilize them. And it's not like we have to wait for the next breakthrough as somebody who has ALS or pancreatic cancer. But the bad news is that we have to, as you say, we have to reach a tipping point in terms of the public awareness and the pressure or the demands that are made on our governments to modify the way healthcare is provided and improving mental health care in particular.
It's a challenge to break through the stigmatization, particularly of schizophrenia, especially when you see such a negative picture being painted, when you see inflated stories of violent behavior, and that being the hallmark of someone with schizophrenia, which is, of course, not the case. And as you say, there is a backstory to that. If left untreated, the symptoms are exacerbated. So it certainly is a very tricky thing that one has to address. And I would like to just know a little bit more about Malady of the Mind, which is very insightful and full of information. Can you just tell the audience a little bit about the book in a nutshell?
Sure. Well, schizophrenia is really the flagship of mental illness. When people think about what is a mental illness, they think about, crazy persons shouting at nobody in particular and acting strange. And these individuals most likely have schizophrenia. And it's the illness that has been, throughout history, there have been illnesses that have been stigmatized and feared. We have leprosy, we had the plague, we have tuberculosis, we had cancer, we even had AIDS, HIV. All of those, were subject to the same type of stigma at a certain point in time in history. But with science identifying underlying basis of the illness, developing treatments for it, those became destigmatized to a large degree and manageable as chronic illnesses. Look at AIDS. In 10 years, it went from being a mysterious, lethal illness that affected two of the most discriminated groups in our society, homosexuals and intravenous drug users. And the lobby, the advocacy to find the answer was so strong that within 10 years, we had treatments, and like Magic Johnson, the basketball star, in 1992. So the AIDS epidemic began in 1980. In 1992, Magic Johnson publicly declared he had AIDS. He's now the president of the Los Angeles Bakers, with treatment. So all these things have overcome the stigma, but not schizophrenia. And it's mental illness in general, but schizophrenia, as I said, is the flagship of this condition. And everybody says that it's true, we talk about mental health more, but we're talking about, but we're not doing it.
Yes.
And the serious mental illnesses, and the most serious is schizophrenia, is the one that suffers the most as a result. Again, if you go on social media, you see these I have pages and pages because I basically download a lot of the stories because they're so compelling. What it'll take, I'm not sure. I can tell you one thing, it's not going to be a cure. And if somebody's waiting for a cure, well, good luck. If there's a more objective means of diagnosis, meaning a brain scan, blood test, genetic genotyping, that is a precise and reliable way of establishing that, that'll help. It's interesting. I talked to a lot of advocacy groups, and there's one group I talked to a while ago, specifically for schizophrenia, And their mission was to change the name schizophrenia, or reclassify it as a neurologic disorder, not a psychiatric disorder. And I said, what do you think that's going to do? I mean, neurologists don't treat anybody anyway. They just diagnose for the most part. Um, uh, and changing the name is not going to, alter the nature of the illness or what
Absolutely.
attention it gets. It may have some stigma. If you think of some other name that sounds a little less pejorative or more legitimately neurobiologic, but so I don't know what's gonna change. As Malcolm Gladwell used in the term he used in his book, reach a tipping point. Um, we're definitely better than ever before, and we're definitely moving forward, but the pace is glacial. And you talk about frustration before. It's very frustrating. So after 40 years of basically doing research on neurobiology and psychopharmacology, I've formed a foundation which is dedicated to the mission of trying to improve the lives of people with mental illness by raising awareness and developing a better healthcare system. But it requires a very strategic approach. And it can't be just a small ground up one off. It has to be a macro solution involving the government. And if the model is AIDS, if you can do it for AIDS, you can do it for anything. So Malady the Mind was really a combination of two inspirations. The first inspiration was the person I would say is the most admirable individual in trying to really bring this out of the shadows is a guy named E. Fuller Torrey, Torrey. And he wrote a book, and he has a sister who had schizophrenia, which was his kind of source of inspiration. He wrote a book called Surviving Schizophrenia. And it was like a manual that told people what nobody else in the medical profession was telling them. But it was written in a very kind of academic way. And then the second source was a good friend of mine is an oncologist named Siddhartha Mukherjee, who's a brilliant doctor, some researcher, but he also is a probably even better writer. He wrote a book called The Emperor of All Maladies about cancer, a biography of cancer. So I wanted to write a book that was going to be, from a narrative standpoint, really interesting and compelling, but also gave you all you needed to know about schizophrenia, from the history to the current status to what you needed to do if you or a family member was affected by it. And it talks about, just forgetting the history, talks about the fact that right now you have treatments that are highly effective, can make all the difference in the world, but they're not easy to find, and you have to go out and identify them and then maybe cobble them together and figure out how they can be paid for. And that's the sad truth of it. And then it demonstrates, how. But it also does something else. It talks about how you need to, particularly at the beginning of the illness, clarify and become certain of the diagnosis. Because, as I mentioned before, you have the illness that occurs in the way that it naturally would occur. You have ways in which the environment can induce the illness, in the same way that fast foods have created obesity, supersize me,
Yes.
or in the same way that we've seen increases in the eating disorders, particularly anorexia, because of the feminine ideal that advertising uses for women. So these are cultural factors.
Absolutely.
And then the third is facsimile. There are some imitations of schizophrenia that occur. So you have to basically, and the family has to push the doctors. It says you have to push the doctors. You need to be, because there's good doctors and there's less good doctors. And in psychiatry, you find more of unfortunately, a broader distribution. And so the family needs their the prize of the prize and the focus of their lives on their children. And the moment they become ill, everything is in the balance. And it should be that they could just go to the best or local hospital or clinic around, and they would be given all that can be provided in terms of our level of our knowledge, but that's not the case. And so, you have to mobilize quickly and try and do what you can. So the book, tries to explain that as well as what the underlying pathophysiological basis of the illness is. And then the other thing that I have there is I had a number of families that consented to be described, publicly in the book. And I show their pedigrees. So I have a genealogist I work with, and it shows their pedigrees. I mean, going back as far as 8 or 9 generations. And it shows how the gene travels through, one line of the family. So I can say with some degree of immodesty, when the book was launched, I had a launch party, and Sylvia Nasser is a friend of mine, and she came to it. So Sylvia Nasser is the woman who wrote the book The Beautiful Mind about John Nash, and her statement was that this is the best book on schizophrenia ever written.
I have no doubt, and I look forward to reading it thoroughly and exploring that. And thank you, Dr. Lieberman, for exploring the many different facets of schizophrenia with us. You've shared some extremely valuable insights, and we look forward to catching up with you again soon to continue our discussion.
Thank you very much for having me, and also for what you do, because this is essential to try and increase awareness and kind of disabuse people of the misinformation that's so prevalent in the media and internet-based media sphere.
Absolutely. And we thank you for supporting that as well. Really, we do.